Okay, good evening, everybody. Welcome to this JROP Institute of Echocardiography, Ultrasound and Vascular Doppler from Delhi.
Good evening, sir.
I request everybody to please mute your mics. We are there in this teaching program for more than 25 years now. These are the couple of people who are the helm of affairs. Then we have two important organizers, Dr. Narang and Mrs. Dina Dua, whom you come across in day-to-day practice. This course is powered by Legends in Cardiology. Training sessions are by leading cardiologists. And we have a number of accreditations, right from Indian Academy of Echocardiography, International Society of Cardiovascular Ultrasound, Alabama, Delhi Medical Councils, then CDM of a Northwest District. And we do run a fellowship training program with Parur University. We have been instrumental in running NHS associated a technicians program in UK. We are the only institute in India for more than 25 years, just completed, and which are known for hands-on training program. This program was conceptualized in 2000 to impart state-of-art world-class training to physicians and cardiologists. More than 5,000 people have attended this program, and we are celebrating the Silver Jubilee in 17th August 2025 in Delhi. April 2000, that was the first program which we did. And now in April 25, this is the 51st program we have been doing. Many of these cardiologists have they become director of non-invasive cardiology in major cardiovascular hospitals. Innovation at all times. Next program, we try to make it better than before. And we have delegates from all over the world. Here's a list of our delegates from around the world. We could see a reverse from Canada, Australia, and USA to have learning in echocardiography. The program of hands-on training is conducted in JROP auditorium in Delhi. Stay of our delegates is in house accommodation on the same complex on first, second, and third floor. And this is very good for the safety of female delegates. Multiple courses are available, as you can see on this list. What we have been doing is now the comprehensive course on echocardiography. This program started on 9th April 2025, and the hands-on is likely to happen on 9th to 22nd of October. This is one person. We can listen to him if it's able to say his voice, who just participated in this program from AIMS Delhi. Little less of a sound, but certainly the voice is audible. And today we are going to deal with M-mode and 2D measurements by echocardiography. And I would like to welcome you all to this particular session. I'm Dr. Rakesh Gupta, again from JROP Institute of Echocardiography, Ultrasound and Vascular Doppler from Delhi. And there we are going to take this program to a next level. That's what we try to do. Let me switch off my presentation, switch on to a different slides. I'll try to be as slow as possible. In the end of a program, I'll request you to write your questions. Then I'll try to answer each and every question one by one. And I'll show you some demonstrations how to measure on images. That's what my quest today for me. Well, all this work which we are going to say comes under the work of chamber quantifications. 2D and MOD is used for what? To look at the volumes, like end diastolic volume and systolic volume for what? LV cavity. So we use volumes for LV cavity. We calculate area like mitral area, and then we decide the linear dimensions of the LV cavity. Why we look at the linear dimensions? To say that whether my LV is dilated or not dilated, whether LA is normal or abnormal. Look at the contractile function of the heart. What is the contractile function? Ejection fractions. Assessment of regional wall motion abnormalities. What is wall motion abnormalities? What are the abnormalities in relation to coronary arteries? And today, when we have a patient presenting in your practice with hypertension, we want to know their LV mass. If we are able to correct the LV mass, if we are able to correct the blood pressure, are we going to correct the mass or not? That's what we look for in this chamber quantifications. Then, following these people over a period of time, we want to understand whether these people have improved or not. For example, if I see my dimensions have become bigger, I treated the patient, my dimensions became normal. I have a person who has got a poor LV systolic function. I gave him appropriate therapy, his LV function improved, and that's what the monitoring is. Certain important points which we look at these is, we talk of a gray scale, gain settings, transducer frequency, depth of image, and position of patients. Well, we did talk about transducer frequency. Adult, we have a transducer frequency of 1.5 to 2.5 megahertz with broadband technology. Depth of image, if I'm imaging a young person versus a neonate, I don't need a depth in neonate, but I need a depth in what?
Adults.
Correct. And position of patient, we want to bring position of the chest on a left lying position so that more of the heart comes closer to the transducers. Reverse happens in dextrocardia or situs inversus. Similarly, if you have a subject who has got a chronic obstructive lung disease, we are not going to push that patient to turn on our left-hand side. Let the patient lie down flat on his back. When he will come for hands-on, then you will realize even these people who are lying flat on their back, they have an excellent window for evaluations. The only thing which I'm going to talk is a grayscale and gain settings. This I'll show you live in my echo pack today. Then word comes of a leading edge, trailing edge. Although this is a concept which is almost 25-year-old, must have gone away by now. But still many people, they ask this question off and on. What is leading edge to leading edge? What is trailing edge to leading edge? What is optimal gain setting? And image are selected and dimensions are recorded in end systole and end diastole. Now, let me start with M-mode evaluation. The concept of leading edge, trailing edges, you look at this image. If I go back to my arrow, you can't see this arrow, unfortunately. Well, look at this image. This has got this point which is closer to chest. This point of this image is away from a chest. For this image, this is a leading edge, this is the trailing edge. Similarly, for this image, this is a leading edge, this is a trailing edge. Center of this marker shows a leading edge and this is the trailing edge. What it means to say that, if my transducer is over here, The edge which is closer to the first intersection, that is known as leading edge. The edge which is away from an intersection is known as trailing edge. So everything has got a width. If you look at my finger, this is a leading edge and this is a trailing edge. Whatever you take LV wall thickness, you take aorta wall, whatever you take, everything has got a definite thickness. The part of a thickness which is closer to transducer is leading edge. The part of the thickness which is away from a transducer is trailing edge. Now, how do you use this complex in a clinical practice? This we have been doing for a long time, but I would like you to give it away at the present moment. Why I want to say to give it away is because at this time, what we are doing is we are not utilizing M-mode evaluations at all. To a large extent, we are using two-dimensions evaluations. And when we talk of a two-dimension evaluations, we are using trailing edge to leading edge. I'll show you in my images quality. Now, second question comes is, what is systole, what is diastole? Whenever we talk of a systole, just take in granted that we are talking of LV systole. When do the LV systole starts? Beginning of the QRS complex to end of T wave. And look at this imaging quality over here. Here is the ECG, the beginning of QRS complex, end of a T wave. So this is systole of interventricular septal thickening. This is a systole of posterior wall thickness. So as the LV contracts, we call them as systole. However, what has exactly happened during this time in aorta? Aorta opens, the aortic valve opens, and the blood is pushed from this LV to aortic valve. So what we look in aorta is we look at this rectangular shaped structure, which is aortic valve. Here is the wall of aorta, anterior aortic root, posterior aortic root, and this is LA size. So if you look at carefully, beginning of systole, what we are looking at, beginning of QRS complex to end of a T wave, and diastole is always end of a T wave to beginning of QRS complex. So if I say end systole means beginning of diastole. If I say end diastole, beginning of systole. So remember these points, which are very, very important, because this is what we are going to utilize again and again in clinical practice. Don't get afraid looking at all these measurements in one. Look, what we need to look at is we'll need to look at M mode, aorta, LA, avicus separation, E point septal separations, LV dimensions, LV mass, then two dimensions imaging is LV dimensions by 2D, mitral valve area by planimetry, LV ejection fraction, RV-RA measurement, RV wall thickness, and vena contract. First imaging quality measurement is M mode evaluations of aorta, LA, avicus separation, E point septal separations. So what do? We go to the parasomnium long axis view. Look, this is plaque view. This is RV, aorta, LA. This is interventricular septum. This is the posterior wall, and this is the LV cavity. If I cut my across basal anterior septum and basal posterior wall, what I'm getting is I'm getting my LV cavity. So this is septum. This is RV. This is RV free wall. So if you look at my ECG, I hope the ECG is seen over here. This is beginning of a QRS complex. So we have this contraction over here for system. So what we measure in this image, we have measured E point septal separation. What is E point septal separation? Opening of mitral valve, that is E wave to septum. And this is 21 millimeters. Normal is 7 millimeters. Many of you can ask me, sir, what is the significance of this E point septal separation? Well, the significance of this E point septal separation is we are measuring virtually in the mid segment of LV cavity. And if this is more than 7 millimeters, it means LV has started dilating. In true concept, if we grow up, where do we dilate? Tummy. So this is the tummy of LV cavity. It's a very good sign just to tell you, look, my LV has started dilating. Next comes aorta measurements. Now, this is a Plaque's view. Again, it's cutting through the aortic valve leaflets. Here is a LA. Look, so this is RV. Here is RV. Here is anterior aortic root. Here is anterior aortic root. Here is a posterior aortic root. Here is the posterior aortic root. And here is the LA. Here is the LA. And then this is LV free wall. LA free wall. Once I'm cutting through it, what do I get? I'm getting RV on the top, then beginning of QRS complex, this is aorta. And in between this aorta, you look at this rectangular box. This is aortic valve opening, and this is opening, this is closing. And when the aorta closes, that is end systole or beginning of diastole. So if I have to measure my aorta, I'll be measuring my aorta at the beginning of aortic root before the opening of aortic valve. So look at this measurement. I've done it over here from this point to this point. Now this measurement is in M mode. So I'll be measuring from a leading edge to the leading edge. Then I go on to measure my AV cusp separation. It's a AV cusp separation. Now, third important thing which I measure is aorta, LA. This is leading edge to leading edge. So aorta, LA, AV cusp separation, I have all measured in M mode by looking at this particular phenomena of leading edge to leading edge. Now, in 2015, what exactly happened is, what we were drawing in M mode across these segments. Now look at this M mode. This M mode is cutting not the basal anterior septum, it is cutting almost the mid anterior septum. But this is the basal anterior septum. So we were overestimating these measurements. So what the guidelines started coming up, why don't we go and measure the LV cavity directly from trailing edge to leading edge? And that's what we try to utilize in today's practice. I showed you M mode measurement, but believe my words, if I have to do it, I'm modifying my LV aorta measurements. I'll not measure from leading edge to leading edge. I'll measure from trailing edge to leading edge, which will constitute something like 2 dimensions imaging. You can do what? You can go and measure LV. When you will measure LV? End diastole and systole. We'll measure at the beginning of systole or end diastole. So this is basal anterior septum, this is basal posterior wall. And whatever this value is, we'll divide by body surface area. Indexed LV dimension should not be more than 32 millimeter per meter square area. Similarly, we'll measure LA. We'll measure LA again in end systole, because LA would be the maximum size during end systole. So we'll measure from trailing edge to leading edge. And this should not be more than 22 millimeter per meter body surface area. Now, normal values. I say, remember very simple word. You don't have to remember aorta to a large size. What we need to remember is my LA and LV dimensions. Look, LA is maximum 22, LV is maximum 32. Very simple. And whenever it contracts, it becomes less than 1/3. Contraction is there. So 932 becomes 90. So 22 millimeters of LA dimensions, 32 millimeters per meter square of a LV dimension. And this I've showed you absolute value. Many of our colleagues must be doing in absolute values. But think of a person, if he has got a body surface area of 2.5, whether this value would be underestimated or overestimated. It will be underestimated. If the LV size is 60, you may say that he is dilated. But if divide this 60 by 2.5, it comes to be less than 2.5 again. So it's not dilated. So in today's circumstances, whenever we talk of measurement, we talk of indexed LA, LV dimensions. Now clear? I'll measure my LV in Plaque's view with mitral valve open, beginning of a QRS complex, end of a diastole, from this point to this point and divide by body surface area to give me a LV dimensions. If I have to measure my septum, I'll measure my septum from this point to this point. If I have to measure my posterior wall, I'll measure from posterior wall from this point to this point. And whenever we are measuring wall thickness, they have to measure during diastole, not during systole. Because if you go back to my previous image, if you look at this image, during systole, these would be thickening. Look, this is thickened during systole. So I have to measure during diastole, septum as well as posterior. Similarly, if I have to measure my LA, I'm going to measure my trailing edge to leading edge from LA cavity. Divide by body surface area should not be more than 22 millimeters per meter body surface area. Now, another important thing comes. What are my volumes? And these volumes, they are derived from two dimensions echocardiographic parameters. So at your level, you can just print this table, post at your place of work, and then you can just refer in case your volumes are high or low. Third important thing comes is LV mass measurement. LV mass measurement has played significant role as on today. Now, if you remember, when we were measuring dimensions, we were measuring in Planck's view. Now we are measuring mass dimensions, we are measuring in personal short axis view at papillary muscles. And we do the same thing. We'll start from this point, measure my septum during diastole, LV cavity during diastole, posterior wall during diastole, then come to septum during systole, LV cavity during systole, and then posterior wall during systole. And machine gives you automatically the two important thing is, it'll give you a regional wall thickness, that is 2 of a posterior wall thickness divided by LV internal diameter in and diastole. So it'll give you RWT. Second thing, machine will give you LV mass. If I go back to my previous picture, it's not there. So it'll give you an LV mass. LV mass during diastole, if it's more than 115 in males, 95 in females, then we say as concentric LV hypertrophy. So till now I said 4 important things. I said aorta, LA, AV cusp separations, and then finally the LV mass by 2 dimensions. Well, just to pass it on, the best method of looking LV mass in echocardiography is by 3 dimensions. And this correlates very well with cardiac MRI. Now looks to our next issues. First issue is 2 dimensions measurements. Look, whatever we were measuring in this cut sections or these images, we are spending a lot of time in M mode measurement. Many of you can say that, sir, even these are 2 dimensions measurements. Even this is 2 dimension measurement. What is M mode measurements? I do agree with you. Like we modified over a period of time. When we started teaching everybody, we said we were utilizing this M mode measurements. Now comes the third important issue is mitral valve area by planimetry. And look, this mitral valve area by planimetry is the most important thing in clinical practice. Because for valve stenosis of mitral valve, the most important issue is mitral valve area by planimetry. Now the question is, how do we measure mitral valve area by planimetry? The best answer is, if you look at this image very carefully, if I'm cutting at the level of papillary muscles and then coming back towards the valve, what I'm getting is a mitral valve area by planimetry. So how do you go that? We go to personal short axis view at aorta. From aorta, we'll come down to what? If I the footprint looks towards the hip is, the first thing will come is papillary muscles. If you further let the footprint looks towards left hip, then you start cutting at the tip of the mitral valve leaflets. And this tip of the mitral valve leaflet, where we measure mitral valve area, is internal size we measure the mitral valve area. This is lateral commissure, this is medial commissure, this is AML, this is PM. And look, commissures are thickened, but they are not calcified. And this is the best way of looking at mitral valve area by planimetry. Now the question comes, the new machines have come, 3 dimensions echo. What they do, if you look at this image, and they give you 100% orthogonal image on the other side. So if you cut at the mitral valve leaflet tips over here, it will give you mitral valve area in true sense. And that's what we rely is 3D guided 2 dimensions mitral valve. So if you really ask me, in today's circumstances, what I've been doing, I don't calculate mitral valve area by 2 dimensions echo. I'll utilize 3D guided 2 dimensions mitral valve area. Now, questions. What is normal mitral valve? Look, everybody, every legend on this world of echocardiography has its own fancies. This was a classification up to 2014. What they said was 2.5 to 4 is normal, mildly reduced to 1.5 to 2.5, moderately reduced 1 to 1.5, severely reduced 1 centimeter. Then suddenly somebody came in 2014. He said, no, what these people are saying is all rubbish. We have a normal 2.5 to 4. We have a common equivalent. Then anything with less than 2.5 is considered as abnormal. What is that abnormality is? Progressive, more than 1.5 centimeter square, severely reduced, less than 1.5 centimeter square, and very severely reduced as 1 centimeter square. To make the things more confused, the JIS in 2023 came out with another. Said, no, we were back. Whatever we were doing long back was correct. So they said, normal mitral area is 2.5 to 4. That is, everybody agrees. But the problem is, now they're talking of mild, moderate, or severe again. And now this severe is less than 1.5 centimeters square. And this severe less than 1.5 centimeters square is virtually the same as we were talking of in 1 over here and 1.5 over here. So this is corresponding more to severely reduced of less than 1.5 centimeters square. Then we have a pressure half time, less than 100 millisecond, more than 150 millisecond, mean gradient less than 5, more than 10, and systolic blood pressure of pulmonary artery more than 50 millimeters. Here is also a catch. Some people say 50, some people say 60. Now, anyone, if you can get up and ask me, what do you remember now? I say, remember mild, moderate, severe. Because whatever the latest is, the more people accept it more easily. So remember mild, moderate, severe. Mild is less than more than 2.5, moderate is 2.5 to 1.6, and less than 1.5 is severe. Why this classification in 2014 came up? Because many people, they were finding 1 to 1.5, but they were asymptomatic. Now they had a gradient of mean gradient of 9, 10. So they said we should have a very severe, anybody less than 1 centimeter should undergo intervention. Anybody from 1 to 1.5 centimeter square should wait, should undergo stress testing, or if is symptomatic, should undergo intervention. Now, same thing has happened over here. This is severe mitral stenosis less than 1.5 centimeter. If they bear all these things, patient is asymptomatic, put them on a stress to look for the symptomatology. If they are symptomatic, put them on a interventions. If they are not asymptomatic, let's wait, watch and see. That's WWF. Anybody who does echo and anybody who tries to learn echo knows only of one single thing in the world, is that ejection fraction. And in the beginning, I'll say it plays 90% of a role in understanding echocardiography. By the time you'll reach 6 months interval of finishing the course, I'll let you know this plays only 10% of the total echocardiogram. Known for 90%, but only plays a minuscule role of 10% in echocardiogram. Now, how do we do it? We call them this as modified Simpson's biplane method. We are not using in one view. We are not doing in Tichol's or Emmott method. We are doing in four-chamber view and diastole and systole. And diastole and systole. Two-chamber view and diastole and systole. And machine will give you combined ejection fraction, which is known as modified Simpson's biplane method. Now, why the word Simpsons? Of course, I'm sure, like if it's discovered by Dr. Narayanan Survase, obviously it will be Dr. Narayan Survase's ejection fraction. So it was discovered by Simpsons. So it becomes Simpsons and two planes were used. That's why he said Simpsons biplane. Somebody else who could not change his name, but he added modified in the sense, Simpson said, let's look at the area and let's look at the length. Area into length will give you volumes. Somebody who could not change his name, he said, no, don't do that. Let's look at this area, divide into individual discrete, calculate their volume, and call them as modified Simpsons. So what exactly? I hope everyone knows how to play carom. Carom has got the what? Board and diskettes. So all this area is divided into individual diskettes and the volume is calculated from individual diskettes and added together to give you a biplane ejection fraction. And that is what is known as modified Simpson's biplane ejection fraction. So somebody asks you a question, which is the best method, two-dimensional echocardiography is modified Simpson's biplane method. Now, the other question is, what is a normal ejection fraction? Well, male is more than 52, female is more than 54. Don't treat yourself as more masculine in comparison to females. Look, they are more masculine than you as far as ejection fraction is concerned. They carry more mass, more ejection fractions. So don't fight with your wife, don't fight with your girlfriend. Look, they have a better muscle mass than you. Well, in this era of 52 to 54 in 2015, somehow is not acceptable. Why is not acceptable? Because what we see ejection fraction majority of time is not 52, 54. We see of 50 to 60%. And that's what 2019, the World Alliance of Society of Echocardiography tried to change it. They says it should be more than 57 in males, 58 in females. And I'm sure this World Alliance of Society of Echocardiography is again dominated by females rather than males. They have not come in the guidelines, but I'm sure in due course of time, they should be in guidelines. Last word comes in coronary artery blood supply. Well, I'm again going to say the same thing again and again. What I use, what is available in my machine, I'm using that. I'm still using, unfortunately, the 16 segment model because there are 16 segment model, 17 segment model, 19 segment models, 18 segment model, all kind of models are available in the world. But my quest of looking at this is always look at 16 segment model, and that is possibly the best thing we can do in life. How do we calculate the 16 segment ejection model is four-chamber view, mid basal septum, mid basal inferior wall is supplied by RC. Mid basal posterior wall in three-chamber view, mid basal lateral wall in two-chamber view supplied by circumflex, and rest all is LAD. Apical septum, apical lateral, apical inferior, apical anterior. And whole of the anterior wall along with mid basal anterior septum is supplied by LAD. Now you can see 4 segments are supplied by RCA, 4 segments are supplied by circumflex, and 8 segments are supplied by LAD. And that's what I want to say is, if somebody comes back with acute anterior wall MI with involvement of mid and basal anterior segment, it means we are dealing with proximal LAD lesion. Well, this is what is the most important thing. Look, this is left anterior descending artery, this is circumflex, and this is RCA. Now, normally this LAD is is supplied to anterior septum, anterior wall. This is basal anterior septum, basal anterior wall, mid anterior septum, mid anterior wall, and then the apex. Sometimes it becomes so large, which we call it type 3 LED, and goes and supplied to the even other side of the inferior wall. RCA supplied to middle basal septum and middle basal inferior wall, circumflex supplied middle basal posterior wall, and middle basal lateral wall. And now, number of times there is a variation in these arteries. There's a branch which is known as PDA. If PDA is attached to RCA, then it's known as dominant RCA. Large branch which goes and supplied to the posterolateral. Similarly, if PDA is attached to circumflex, it supplies to the RCA territories. So dominant PDA, dominant LCX, wherever the PDA is attached, we call them as dominant arteries. Same pictorial diagrams, same views talking about this. This is, I always remember, is middle basal septum, middle basal inferior wall. This is what? RCA. Circumflex is middle basal posterior wall, middle basal lateral wall is circumflex, and rest all is LED, LED, LED. Some people, they started using 17 segment model where the apex is itself is separate to talk of 17 segment. And they went on to classify this a little bit modification. Now, what is the modification they did was, this is closest to cardiac MRI. So if this is septum over here, this is what? Lateral walls. This is anterior, this is inferior. So we have this divided this segments in 4-chamber view where the apical septum and apical lateral wall remains the same thing. This become mid-inferior septum, basal inferior septum. This become mid-anterolateral, basal anterolateral. Similarly, this apical inferior, apical anterior remains the same. Mid-inferior, basal inferior, mid-anterior, basal anterior. Again, things have, the posterior wall became mid-infrolateral and basal infrolateral. And apical septum and mid-anterior septum remains the same thing. Not to confuse you too much, either you can remember this 17 segment model or 16 segment model, which is convenient to you. Whenever we are not able to get a good imaging quality, that's what we used in our lab is, this is micro bubbles used for LV opacification. We push in micro bubbles in the RV. Because of the size of less than 6 micron, they comes and opacify into the LV cavity. And look how beautifully they give you a value of LV contractions. So this is a bubble which is filling up. Now you can see a beautiful LV ejection fractions. You can calculate ejection fraction like this. Couple of words about advances. What is advanced LV function evaluation? Look, this is what is known as tissue Doppler imaging. Till now, what we were doing is we were looking at the flow velocity of the blood across, and we were getting rid of low flow velocities. Now here's some intelligent person what he did. He said, I'm not going to look at the flow velocity. I'm going to look at the myocardial thickening or deformation in these segments or annulus. And we have 5 annulus, septum and lateral in 4-chamber view, anterior inferior in 2-chamber view, and posterior annulus in 3-chamber. So what he said is, let's put a sample volume in tissue Doppler imaging at the medial annulus. And what do we get? We get this is S wave or systolic thickening. Then there's a period which is known as isovolumic relaxation time. We get E prime wave, then A prime wave, and the mitral valve closes. And before the aortic valve closes, there's a word which is known as isovolumic contraction time. So if you look at your cardiac cycle, there's one systole. Before systole, there's isovolumic contraction time. There's one diastole. Before diastole, there is an isovolumic relaxation time. And diastole itself is first ejection wave, then diastasis, and then the atrial contractions. So much so that the systole and diastole is relatively bigger as compared to systole. Heart takes longer time to relax, then contracts. And this is what is known as S wave. And we take this sense wave across all annuli, like in this four-chamber view. This is septal annuli, this is lateral annuli. This is more than 7 centimeters. If it's less than that, possibly there's some function, either basal and septum, mid septum, apical septum, they are less contracted. And what is the most important thing which I utilize in my clinical practice? A patient of dilated cardiomyopathy comes to clinic. I do not know whether this is dilated cardiomyopathy or ischemic cardiomyopathy. How do I differentiate? Very simple way I utilize in my practices. I look at the TDI velocity across all annuli. If my TDI velocity is all uniformly reduced instead of 7, which is normal centimeters per second, if it's 4 across all eyes, I think possibly I'm dealing with dilated cardiomyopathy. If these velocities are variable, suppose the velocity in the lateral and posterior wall annulus is more than 7, septal anterior inferior is 4, it means there's a differential velocities. It means I'm dealing with ischemic cardiomyopathy. That's the way we look at these people presenting for the first time with cardiomyopathy. What is tissue Doppler imaging? This is only looking at one dimensions. But the heart does not contract in only longitudinal dimension. It can go in this fashion, it can go in this fashion, it can go in this fashion. So we've moved on to look at 2 dimensions, TDI or longitudinal strain. And what this longitudinal strain has been started doing is, instead of looking whole of the septum, we started looking at the single basal septum of this particular wall. And look how much is thickening. And that's what we try to measure. And the normal thickening is minus 20%. And this we do virtually in all segments of 4-chamber, 2-chamber, and 3-chamber view, so that we get an exact idea. Look, every segment is represented over here for systolic thickness. And its number is given is 15, 18, 24, 23, 21, 17. And across all this, the number is average of these numbers is what is the global longitudinal strain. We are going to discuss a little bit of it whenever we talk of advances in LV function evaluations. These are gimmicks. Look, somebody wants to give you something to buy, and when they want to buy something good, they all create these kind of phantoms. And they attract persons. Look how good it is. But this is not true. The true ejection fraction is looked over here. We look at the 4-chamber, 2-chamber, and 3-chamber view. Together, they'll give you an ejection fraction, because our heart is a volume. Heart is not a slice of a bread. So it gives you an ejection fraction, which is seen over here is end-diastolic and systolic ejection fraction, stroke volume, cardiac output, and heart. And this is true, it is available. But how many times we are using it, that's a little controversial. This ejection fraction correlates very well with cardiac MRI. And now, what is this ejection fractions give you? It gives you end-diastolic volume, it gives you end systolic volume. Apart from that, the most important thing which is giving you is the time of synchronous contractions. Look, this is aortic valve closure. So all segments, they have contracted at the same time at the aortic valve closure. So it tells you about synchronicity. That is contracting at the same time. At the same time, it's telling you how much it's contracting. That is synergy. So that is the advantage of this 3 dimensions echocardiography is they give you synchronicity as well as synergy. Now, whatever we have done till now, I'm sure it must have gone a little slow. I know it's a very difficult answer to understand at this moment. But I'm comfortable, you are comfortable. Let's go and measurement a few more things before I show a live demonstration and take your question. Another important thing which you always measure is LVOT diameter. Plaques view. Both the leaflets are open on the aortic valve. Hinge point of right cornicus, hinge point of non-cornicus, that is what is known as LVOT at your level. Normally it's about 20 centimeter, 20 millimeters. Then I'm not going to talk of aorta measurements. Then second important thing, what we measure is a LA area. We did measure LV area. So we are going to measure LA area during end systole. We trace the area and you get the area. If you multiply by this, you get LV volumes. I'll stop over here because I'm not going to talk about right chambers at the present moment. Whenever we'll talk of right heart hemodynamics, we'll be coming back again to these chambers. So I'll hold on my presentation over here and take your questions one by one. You can just raise your hands so that I'm able to answer your questions. And intermittently, whenever I'll get answer I have to apply for, then I'll go for my live online demonstrations to show you at the same time what exactly you are looking for. The first question comes from a very young man with his name of Shehbaz Kareem. So, Shehbaz, I'm so sorry to say these words. I do not know what your roll number is.
So actually, my roll number is 6 in non-attending workshop. I'm not attending workshop, sir. My roll number is 6.
Roll number is 6.
Yes, sir.
Dr. Shehbaz, I'm sorry, I couldn't figure your name in this list. Are you using somebody else's laptop?
No, no. My roll number is 6 in non-attending of workshop, sir. I'm not going to attend
Okay, okay,
workshop.
online. Okay, I got it.
Yeah, yeah.
So we'll send you a list again today. Just name your number according to the same thing. We call them as JROP slash 51 slash April 25 online slash 07. Okay, I'll request you to do that.
Yes, sir.
Go ahead, Shehbaz.
Okay. Sir, many of times we are getting a jerky septum, especially in the patient who is having left bundle branch block changes in his ECG. So many of times we are getting a septum which is a bit jerky, and we are not able to measure or quantify the exact systolic thickening of septum at that very time. So in such circumstances, how we should go, because many of time we are not using modified Simpson's method to calculate the ejection fraction. We are preferring the eyeballing. So in such circumstances, what is the exact criteria, or what is the exact way to calculate that very contractility or systolic thickening of IBS, sir? Because many of time especially in a left bundle branch block patient, we are getting jerky symptoms. So.
True. Your question has got three important parts. One is jerky septal motion does not allow you to look at a wall thickenings. Correct?
Yes, sir. Yes,
Second
sir.
is does not allow you to do your ejection fraction.
Yeah. Yes, sir.
Third is this jerky septal motion is normal or abnormal?
Yeah, exactly, sir.
Let me take in reverse fashion. Suppose it's LBB presenting with the jerky septal motions and is an involvement of anterior wall MI. Then you look at anterior wall.
Anterior one.
If it's anterior wall MI, anterior wall would be affected. If it's not an anterior wall MI, it's a pure LBB, anterior wall will not be affected.
Yes, sir.
2. How do you calculate ejection fractions? I said modified Simpson's biplane method. What will happen in jerky septal motion? It means that when the other segments are contracting, it's going out. So what you will do? You will underestimate your ejection fractions. But on the other hand, if you go to two dimensions view, that is anterior inferior wall, you'll have get the correct ejection fractions. Correct? Now I'll show you an image where a jerky septum of LBB you can appreciate very well that look, this jerky septum is contracting normally. Give me a second. I'm going to bring that. Now look at this septum. This is definitely thickening. This is LBB. It is jerky, but it's definitely thick. And if you are not really sure what you're looking forward, go for an M mode. Look, in M mode, when this is contracting, this is going back. So, but it's still thickening. And that's how you differentiate your LVB is thickening or not thickening. Utilize both 4-chamber view and 2-chamber views to calculate your ejection fraction. Look, this is again jerky septal motion. It is thickening, but you cannot appreciate. You can only appreciate when you see it again and again.
That exactly the same thing is happening, especially in jerky septum. We are getting the contraction of this very basal septum as well as mid septum. But many of times we are confusing that the distal septum is contracting or not. That's why we are not able to appreciate whether there is
Zoom it
RWMA
up.
or
You
not.
know, you have to spend time. How many echoes do you do every day?
Sir,
Oh,
approx 8 to 10, sir.
how many echoes? How
8
many
to
echoes
10.
do you do every day?
Sir,
Whenever you get these kind of a thing, just focus on
10, sir.
zoom it up
Approx
and
10 echo
focus it.
every day, sir.
Just zoom it up and focus it. Okay. So let me take Dr. Tajinder Kaur, the next one.
Okay,
Dr.
sir.
Tajinder Kaur, you can lower your hand.
Okay, sir.
Shahbaz, just lower your hand and let Dr. Tajinder Kaur ask me the question.
Good evening.
Good evening,
Yes, sir.
Tajinder.
Good
I'll
evening, sir. Sir, there is power failure here due to weather condition, and I missed your slides from M mode to my well planimetry.
Tajinder, I'll
Can
send
you
you the video recordings.
again, please? And doubt, then can I explain questions in the next meeting?
Yeah, sure, 100%. You can next meeting, you can ask the questions. Anyone you want to ask. All right.
Thank you, sir. Thank you, sir.
Thank you. Let me take roll number. I can't say. Dr. Veena Bang. Dr. Bang,
Please elaborate on calculating EF in M mode, in Planck's mode, and short axis mode.
we don't calculate EF in plaques and short axis. Dr. Bang, we are in 2025. Try to understand what has been said is if we calculate ejection fraction in M mode in plaques window is what we are cutting through. We are cutting through only basal interseptum and basal posterior wall. Suppose you have apical infarct. So what will happen to basal interseptum, basal posterior wall? They will be hypercontractile to accommodate whatever the mass is lost, contraction mass is lost in apical segments. When the true ejection fraction is only 35%, it'll give you an ejection fraction of 60%. So you have to give it up completely. There's no way that you can calculate ejection fraction by M mode in Planck's view or short axis view. We are looking at a global ejection fraction. Ejection fraction complete of a LV cavity. When we are talking of 3 dimensions ejection fraction, how can we depend only single 2 segments to talk of wall motion or ejection fractions? No, we should not use it. We should condemn it.
Okay.
Believe my words, number of times we had a problem in the past. Patient came up with 50% ejection fraction to the cath lab. We did an angio. Without realizing the fact the patient was carrying only 24% ejection fraction. And this M mode ejection fraction was calculated by M mode. And you can imagine in cath lab, patient having 24% ejection fraction, you're doing angiograms. If somebody is still doing it, I do not appreciate that particular person. Either he is not read, he is poorly read, he is absolutely not updated. Any other question? I would love to answer, Dr. Bang. Shall I move to next person, Dr. Bang?